Good evening from Madrid to all of you. Good morning to Dario from New York. First of all, thank you very much for joining us and welcome to this KnwoEMS webinar. I'm sorry for we are a few minutes later due to technical problems, but we will start right now. So, with no more delay, let's start now. Thank you for joining again and welcome to this KnwoEMS webinar. My name is Paloma Rey from SAMUR Protección Civil, which is an emergency medical service operating in the city of Madrid. Let me just mention that the presentation will be recorded so that the slides and the recording will be shared on the different platforms of the project. The topic for today is focused on pre-hospital management of acute stroke. During the next hour or so, we will hear about how several EMS in Europe and Israel deal with this time-dependent condition. We have speakers from Ireland, from Romania, from Israel, and from Spain. A stroke is a leading cause of death and disability worldwide. I'm pretty sure that all of us attending this webinar are clear about the need for and importance to early reperfusion in acute stroke. The approach to patients may be in some way different in the different organizations that we have represented here today, but for sure we have the same objective when dealing with a patient suffering from an acute stroke. And that is what this webinar is about. It's about to share experiences, best practices in the recognition and treatment of acute stroke so that we can learn from each other. In benefit of time, I would kindly ask you to post your question, if you have any, in the Q&A function to be addressed by the end of the webinar. So before I start listening to the speakers, I would like to give the floor to Lisa Meyer from Johanniter, which is the organization leading the administrative part of the project. So she's going to briefly introduce the KnwoEMS project. Michelle, over to you.
So hello and welcome everybody. I'm happy that you could all attend today, and I will just explain a very, very short time because I don't want to waste your time because we have very, very interesting presentations ahead of us. But I want to tell you something about the reason why we're here. It's the KnwoEMS project, and this is a project co-funded by the European Union. We are from 7 different countries, from 6 countries. We have SFMC from France, we have APHP from France, we have SAMUR PC from Spain, we have KnwoEMS from Portugal, Magen David Adom from Israel, and DSU from Romania. And this whole project is based on another project, which was called No Fear, and the full name is a network of practitioners for emergency medical systems and critical care. And during the COVID pandemic, it was made clear that the countries aren't connected and we could have learned a lot from each other. So we could indicate priorities for standardization and so on. And in the end of this project, the project partners didn't want this knowledge exchange to end. So this is the reason why KnwoEMS was founded. And we are doing monthly webinars on very interesting topics and will be held on every first Thursday of every month. And the past topics have been, for example, EMS organizations and the Madrid metro bombing, management of burns, mass incidents, emergency services, and mass gathering events. And all the webinars have been recorded. So if you missed them, check out our YouTube channel. All the recordings are up there. and we are always looking for new topics. We already had some interesting topics, but if you have something in mind, what you want to discuss, to be discussed, or do a presentation on your own, please scan this QR code and bring your ideas in. And if you don't want to miss anything, then become a part of our KnwoEMS network. And you will get a monthly mail for the next webinar and different other interesting happenings. And as we have the 6th of March right now, and in 2 days, Saturday is the International Women's Day, the whole KnwoEMS consortium wants to thank all the women doing their service in firefighting, EMS, and police, and so on. So thank you.
Thank you very much, Michelle. So we go directly to our first speaker. He's Fernando Monforte. Fernando is a medical doctor, a specialist in family and community medicine, and an emergency physician in SAMUR, Protección Civil. He regularly collaborates as an instructor and teacher in multiple undergraduate and postgraduate training activities related to emergency medicine. For several years now, Fernando is a paid staff physician, but he has been a volunteer in SAMUR since he was 18 years old. Okay, Fernando, the floor is yours.
Okay, thank you, Paloma. Wait for the presentation.
I didn't receive it now.
Email.
So maybe we should start with another presentation till I have Fernando's mail.
Okay, so we can go to Israel. Shafir, are you ready?
Yes, I am. Can you hear me?
Okay. Yes, perfectly.
Okay,
Loud and
perfect.
clear.
So let me
Okay, let
share
me
my
introduce
screen.
you. Yeah, let
Okay.
me introduce you briefly. Dr. Shafir Botner is the director of Magenta Vida Dom's Paramedic School and one of the only a handful of paramedics serving in MDAs, MDA medevac helicopter and ECMO units. Shafir started with the organization as a youth volunteer at 15 and quickly rose through the ranks, serving as a chief paramedic and being later promoted to paramedic supervisor. Okay, Shafir, over to you.
Thank you for having me, and thank you for the introduction, Paloma, and good evening, good morning, good night, everyone. So, yes, I was not planned to be first, so I didn't want to go over about stuff that other people before me will speak, but they will speak about their stuff later on. So let's just dive into my presentation, which we called her "Faster is Better" if dealing with stroke. So a short brief about what we are doing and how can we make, at least for us, things better. So several things that we are putting our focus on is quality indicators. Of course, I will elaborate about each one of them later on. Fast lane for patient with suspected CVA or stroke diagnosis, fast lane at the hospital. Dispatcher tools, for example, video chat with the patient, timer, dispatcher guidance cards, etc. Medics and paramedics tools, we embedded in our MADA app a computerized fast ED scale for evaluating patient with suspected LVOS, large vessel occlusion stroke, transportation of suspected LVOS patient to hospital with cerebral catheterization capabilities. We are doing some research. We just published a review about evaluation of added value of ambulance transport of stroke patient versus self-referral of patient to the hospitals by themselves. And coming soon, I will elaborate it later on, mobile stroke unit with CT scan that we're going to launch here in Israel. So if speaking about quality indicator for stroke, we are monitoring every patient that has a suspect stroke, about the team performing fast scale exam, blood pressure, of course, performing DEX test, and even writing down the last known normal time. We are also measuring early hospital report, which means the team reports to the hospital from the scene that he's about to come with the patient in order to get the ER ready. I will speak about it in a few slides. And the quality indicators compliance with our teams is 97 to 100%. I know it sounds very high percentage, but that's because our medical records are computerized, and that's mandatory. If you are putting a suspected stroke code, so you must write down all the quality indicators, so the compliance is very high. FastLan for suspected stroke. This is a project that we have with joint venture with many hospitals around the country. Following our early report, a neurologist is receiving the patient in the ER, and the patient, in some cases, is transferred directly to the CT scan with our gear, which means he stays on the ambulance gurney, and they take him directly to the CT scan. He is not stopping at the ER, and we are not transferring the patient to the hospital bed. And if the CT scan is not available or the cath lab is not available, the patient will receive early TPA. That's, of course, regarding or according to the local or the specific hospital that got the patient. But in general, that's the drill. Transportation of suspected patient with large vessel occlusion stroke to hospital with cerebral catheterization capabilities. This is active in Israel since 2019. Of course, the aim is transporting the patient with high probability of LVOS directly to hospital that can do catheterizations. Of course, we have criteria for that, and the team in the field knows, the BLS and the ALS teams, by the way, knows that if the patient meet those criteria, they will try to admit the patient to the designated hospital. Our criteria is clinical criteria, which means performing fast ED, using fast ED scale. Of course, the patient or the family has to agree. The pre-hospital time added the transport time will be less than 30 minutes, which means we will not go with the patient above 30 minutes just to get to a designated hospital. And of course, no known contraindication for admitting the patient to cath lab. As I mentioned, we're doing some research. We did a research with one of our biggest hospitals in the south of the country, and we tried to measure the added value of MDA early assessment and transportation versus self-referral of patient to the ED. And we took about 1,200, almost 1,300 patients that were admitted to this research. And the most important outcome of this research is that door to CT time is 42 minutes for EMS group versus almost 100 minutes, 99 minutes for several referral patient. So one of the latest outcome of that is developing more awareness and awareness program in the public in order to shorten the time of self-referral or to call an ambulance, which is supposed to be intuitive for all the public. And if speaking about coming soon, we're just now in the middle or in the peak of building or launching a new mobile stroke unit. This is also a joint venture with Bellinson Hospital, which is located in a very big city in the center of Israel, together with the Ministry of Health in Israel. And that's, of course, will be another mean to shorten the time to needle period. And the project will be, of course, at the beginning, it will be a pilot in a large metropolitan area in the center of Israel. And the topic or the main issue of this project is to send this unit to a suspected, together, of course, with a regular ambulance to the suspected patient with a stroke, and to perform a CT scan on site. And in case we will, the neurologist will decide that this is an LVOS, and this is not, of course, an hemorrhagic stroke. The patient will start get TPA on site, shortening the time of getting TPA. I hope I did it with the time frame that was scheduled, and I guess it's a slide for question, but question perhaps will be at the end of the other presentation. So thank you very much for your time, and I'll bring back the floor to you guys.
Okay, Shafir, thank you for such an interesting presentation. So we are going to Ireland. Are you ready, Shane?
Yeah,
Okay.
thanks very much.
Let me introduce, because we still have some technical problem with one of the presentations. So we are changing the order of the. So from Ireland, we have to welcome Shane Devlin. He has an advanced paramedic in the National Ambulance Service, working in clinical practice, education, and research. Shane completed his education in emergency medical science in the University College of Dublin in 2022, and he has published numerous papers in peer-reviewed paramedic journals with the focus on paramedic recognition of posterior circulation stroke. So, Shane, go ahead with your presentation, please.
Thanks very much there. I'm just going to share my screen here. Okay, folks, can you see that? Can you see that, folks, there?
Yes.
Yeah, perfect. Thanks very much for having me here. So just repeating there, Shane is my name. I'm an advanced paramedic with the ambulance service in Ireland, working in clinical practice, education and research. And I'll just give you a whistle-stop tour on how we treat stroke in the pre-hospital environment in Ireland. First, a little overview of Ireland. So it's renowned for its lovely scenery. That's actually near my house in Donegal. For its culture and music. We have a great rugby team and great pints of Guinness. And as per the last census, there's 5.38 million people in Ireland at the minute. And what about the over 65? So the age group of over 65 has gone up 40% in the last 10 years to over 800,000 in Ireland. And it's estimated by the year 2051, there'll be 1.6 million people over the age of 65 in Ireland. Our last audit of stroke in Ireland showed that there was a 7% increase in stroke in the last year, with a mean age of 70 years of people having stroke. So what does this mean for the ambulance service in Ireland? It means there's going to be a larger population of older people, and therefore we're going to be busier with stroke patients. So a little bit about the ambulance service as well. We're the main emergency ambulance provider for the state in Ireland, with the exception of County Dublin, where that is shared with the Dublin Fire Brigade. So we have over 1,600 staff spread out over 100 different locations in Ireland, and we respond to over 300,000 calls per year. We have an intermediate care service that does 40,000 transfers between hospitals and other patient facilities. We have a helicopter service manned by an advanced paramedic that carries out over 800 missions. We carry out over 600 pediatric or neonatal transfers. And we've got over 300 community first responder schemes in Ireland, and they respond to chest pains, cardiac arrest, stroke, and choking in the community. So briefly, what is the level of practitioner that's responding to patients in Ireland? Broadly, there's three. There's EMT, paramedic, and advanced paramedic. So the EMT brings a basic life support level to the patient. Their main duties are in patient transport, but whenever the emergency ambulances are very busy, they may be utilised for frontline 999 calls. Emergency ambulances are manned by paramedics and advanced paramedics. Paramedics provide an intermediate life support level. They can do advanced airway management with supraglottic airways, manual defibrillation, and can give around 27 medications. And the advanced paramedic delivers an advanced life support level, is capable of IV and IO cannulation, endotracheal intubation, and can give around 50 medications. So when the patient rings for an ambulance, they're assessed by our call taker, who will do a fast assessment over the phone, and then a dispatcher will look for the nearest ambulance to be sent to the patient. And this is our clinical practice guideline that we will follow when we get to that patient. So if there's neurological symptoms, we use the FAST test in Ireland to determine if the patient has a stroke or not. And very importantly here, we always try to check the blood glucose level to try and rule out abnormalities in that as a stroke mimic. Then a little change in our CPG here. If they're FAST positive with an onset of less than 4.5 hours, we typically would take them to a specialized stroke hospital, but that has been extended with the introduction of mechanical thrombectomy in Ireland. So that's extended typically to less than 24 hours in Ireland at the minute. So the main thing that we want to do as an ambulance service here is recognize potential stroke patients and avoid the local hospital and take them to a stroke center capable of thrombolysis and looking after this specific patient. So as I said, with thrombectomy in Ireland, that's another avenue that we want to offer these stroke patients. At the minute, it's only available in Dublin and in Cork. So because it's only available in 2 parts of Ireland, we need protocols in place to ensure ambulances make it to the thrombectomy centres. So the pit stop protocol is one of these, and basically it's where you go to your nearest stroke centre, get a scan and get treatment, and then if necessary move on forward to the thrombectomy centre then. So the inclusion criteria is if the patient is over 16, is FAST positive, and it's less than 24 hours. And you'll note that's different to the 4.5 hours for thrombolysis that was in our previous guideline. So when we have our patient, we're moving en route to the hospital. We're going to ring the hospital with a name, address, date of birth, and next of kin, and the hospital will then use that to pre-book the CT scan so that there's no delays when we get to hospital. If an advanced paramedic is on scene, they'll insert an 18-gauge cannula into the patient's arm, and this is to facilitate CT contrast at hospital, again, to reduce minutes at the hospital and get the patient scanned and treated as soon as possible. The paramedic crew will stay with the patient while they're assessed at hospital, and the patient will be assessed on their stretcher, and we will take that patient to the CT scanner. When the CT is complete, we'll take the patient back onto our stretcher until a decision is made regarding the onward transfer to the thrombectomy centre. And the initial pilot project for this has shown that there's been a reduction in thrombectomy times up until 1 hour, which is amazing, because previously with thrombolysis, 1 minute could save 1 day of healthy life for a patient, but 1 minute shaved off time to thrombectomy could shave up to a week of healthy life for that patient. So that's a great result for that project. So we want to avoid the local hospital, do a pit stop in the local stroke centre, and be sent on for thrombectomy then. That's what's working with the pit stop protocol at the minute. Another local project happening is the large vessel occlusion project happening in the Beaumont Hospital catchment area in Dublin. And as you remember, Dublin is one of the areas that can provide thrombectomy. So this were all fast positive patients in this catchment area. We complete an extra scan or an extra test for these patients called the ACT FAST test. So it's the arm, chat, and tap assessment. So it all depends on which arm is weak. So if the right arm is weak, we assess for a severe language deficit. So typically, in over 90% of the population, the language centers are on the left-hand side of the brain. So if you've got a right-sided weakness and a language deficit, that indicates that it's more likely to be a large vessel occlusion stroke. And then if you've got a left-sided weakness, then we're going to look for either a gaze away from the side of the weakness or towards the stroke, and a neglect on that side. So if you were to go to the left-hand side, tap them on the shoulder, that patient might have a complete neglect that you're standing on that side. So any of those would make the patient act fast positive, and that would be an indication to send us to the thrombectomy centre. So we would let the hospital know that the patient is now ACT FAST positive, and then we're going to call the stroke physician directly by mobile then to let them get enough notice to set up the thrombectomy suite. In the future, in a local catchment area, it's hoped that we avoid the local centre for thrombolysis and go straight to the thrombectomy centre with our large vessel occlusion strokes. So what does the future hold? Currently, there's a quality improvement project in Cork University Hospital, and that aims to streamline both the hospital and pre-hospital processes to reduce time to CT, time to thrombolysis, and time to thrombectomy. There will be a further rollout of the ACT FAST for large vessel occlusion bypass once the pilot project is finished. And there's currently research on developing pre-hospital guidelines on paramedics detecting posterior stroke. So I always try to include my dog Cooper in any of my presentations. So that's him with his Valentine's Day groom with his little tie there. Thanks again for having me. It's been a real privilege to speak to you today, and I welcome any questions at the end of the presentations. Thanks very much.
Okay, thank you, Shane. Thank you for sticking right to the time and for your interesting presentation. So can we go to Fernando now?
I think so, yes.
Yes. Okay, Fernando Monforte, the floor is yours.
Oh, okay, perfect. Thank you. Good afternoon, everyone. Thank you for attending to this seminar. Today I will be presenting on the pre-hospital management of acute stroke. So all of us know that a stroke is a time-dependent emergency, and early recognition and treatment significantly impact patient outcomes. So next slide, please. A stroke is a medical condition that happens when the blood supply to a part of the brain is cut off, and this can be caused by a blockage of a blood vessel in the brain. an ischemic stroke or a bleed from a blood vessel in the brain, an hemorrhagic stroke. So the statistics show that about 13% of strokes are caused by hemorrhage, and about 87% of strokes are ischemic strokes. So although there are signs and symptoms that may indicate a particular type of stroke, such as headache and decreased level of consciousness in case of hemorrhagic strokes, a correct diagnosis requires a specific imaging tests. So patients with hemorrhagic strokes are likely to require neurological assessment. In ischemic strokes, early reperfusion is essential for patient outcomes, and to achieve this, the therapeutic strategy may consist of fibrinolysis or, in case of acute large vessel occlusion, thrombectomy. Next slide. So let me to share with you some facts about a stroke. Really, stroke is a major global health issue. Every year, over 12.2 million people suffer a stroke, and 1 in 4 people over the age of 25 will experience a stroke in their lifetime. So in Europe alone, there is more than 1 stroke per minute, and the economic burden is also significant, with an estimated cost of nearly 60 billion of euros in 2017, projected to rise to 86 billion by 2040. This makes stroke an urgent and public health challenge. These incredible numbers require an incredible strategy. Next slide. So as emergency medical services, we are often the first point of contact for stroke patients. So rapid assessment and transport can make the difference between recovery, full recover, and long-term disability or death. Our role is crucial in identifying stroke symptoms, initiating pre-hospital treatment, and ensuring timely transfer to specialized stroke centers. Next slide. The pre-hospital management of stroke involves several key steps: symptoms recognition, EMS care, patient evacuation to referral hospital, and hospital handover. Each of these steps must be optimized to reduce delays and improve patient outcomes. Next slides. So our emergency medical service is SAMUR. SAMUR Protección Civil provides emergency medical care on the city of Madrid for Madrid's nearly 3.4 million residents plus tourists and commuters and we operate in the public areas of the city of Madrid. Next slides. SAMUR PC stroke care strategy includes training first responders in the recognition of the pathology of symptoms compatible with strokes, the stroke code guidelines of the Autonomous Community of Madrid, and our operational and clinical SOPs for the dispatch center, the basic life support units, and the advanced life support units as well. When the dispatch center detects symptoms that are compatible with a stroke, it sends an advanced life support unit to the scene with a doctor or nurse and an emergency medical technician. If it's a basic life support unit that detects symptoms compatible with a stroke, it notifies the dispatch center, which activates an advanced life support unit. Once the patient has been assessed by the doctor of the advanced life support ambulance, if the patient meets the criteria for the stroke code, the dispatch center activated the head doctor on duty and the head nurse on duty and manage the activation of the stroke code and the pre-alert to the stroke team of the corresponding hospital, according to the assessment of the Madrid Direct Scale and the NHSS and the geographical location of the incident. So, meanwhile, the unit stabilized the patient, and I would like to note that all of the advanced life support ambulances of SAMUR PC have a point of care basic blood analysis that allows other pathologies that can simulate a stroke mimics, to be ruled out. Next slide. So this huge slide, in this huge slide, you can see all of our inclusion and exclusion criteria for the stroke code, including a specific code for pediatric patient. So the patient must have an acceptable baseline condition, and the symptoms must have been present for less than 24 hours, or if the symptoms have unknown evolution. Next slide. These are our data for 2024. We activated the stroke code 259 times, and in 80% of the cases, finally, it was confirmed that it was a stroke, and 20% corresponded to pathologies that simulated a stroke, so a stroke mimics. Of the total activations, as you can see, of the stroke code with final diagnosis of a stroke, in 37% of the cases, the stroke was hemorrhagic, and in 63% of the cases, it was ischemic. Thrombectomy procedure was performed in 62 cases. And of the total activations of the stroke code, 13% corresponding to other causes of neurological origin and 7% to other causes not of neurological origin. Next slide. So in this graph, you can see the proportion of ischemic strokes and hemorrhagic strokes during all the year. You can see that they keep similar, with a similar distribution during all the year, except August. And the explanation of this is that there are fewer activations because Madrid residents tend to go on vacation to other places. And therefore, the potential number of patients also decrease. So in the graphs located at the bottom right of the slide, it can be seen that age and sex in ischemic stroke and hemorrhagic strokes follow a similar distribution without the important difference. Next slide. So the medical stabilization, when once a stroke is suspected, we focus on maintaining optimal physiological parameters: oxygenation, blood glucose, blood pressure, temperature, and airway management if needed. Keeping the patient in a normal state helps prevent further neurological damage and enables access to hospital reperfusion treatments. The characteristics of each center are essential in determining the optimal destination for our patient. So in our case, it's very easy because the fact that we are located in a large city, we have quite access to major hospitals with high capacities and resources. We refer to hospitals that can provide thrombectomy treatment at that specific moment as stroke centers. I will explain that in the following slides. And stroke centers may vary depending on the time of the day and the day of the week, as we will see, as I said before, in the next slide. Next slide, please. Perfect. All the hospitals to which we transfer patients with a stroke code have a stroke unit and the technical capacity to perform thrombectomy. So on weekdays during regular hours, all hospitals operate as stroke centers. Remember that we call stroke centers to all hospitals that are thrombectomy capable. But on weekday evenings and nights, weekends and public holidays, there are only 3 reference centers in the city of Madrid for thrombectomy with the necessary personnel, the necessary staff, plus 1 additional center for pediatric stroke. And obviously, our dispatch center knows the schedule in advance of what centers are thrombectomy operational in every day. Next slide. We use the NHS and Madrid Direct as predictive scales for suspected large vessel occlusion. So, considering the information presented in the previous slides, patients with an NHS less than 10 are transported to a hospital with a stroke unit, while patients with a NHS greater than or equal to 10 are transported to an operational stroke center, meaning a hospital that has the capacity to perform thrombectomy at that specific moment if necessary. And all stroke centers have neurosurgery services as well. Next slide. So their operational times objectives are very important because stroke, as you know, is a time-dependent condition and time management is crucial. So these are the objectives of the stroke code in Madrid and our operational times. It's important to know what are you doing in order to improve your results. Next slide. So typically, a patient handover to the hospital stroke team, the neurologist, takes place in the emergency department resuscitation room. But in my opinion, there is an obvious area for improvement here because the patient, all stroke patients transferred by SAMUR have been evaluated before by a doctor. So all stable and not intubated patients should be transferred directly to the city scan, to the city room. Next slide. And also, I would like to note that it doesn't end with the handover. At SAMUR PC, we follow up the cases at 6 hours, 24 hours, and 7 days to track in a telematic way to track their outcomes and to identify areas for improvement. And we also organize joint clinical sessions of combining pre-hospital and hospital teams to stay updated and share interesting clinical cases. Next slide. And to summarize, emergency medical services plays a vital role in early stroke recognition and management. Time lost is brain lost, every second counts, and continuous training, structured protocols, registries, investigation, and quality measurement are essential to improving stroke outcomes. Next slide. If you want to know more about us through these QR codes, you can access to our SOPs and clinical guidelines that we use in our ambulances. Next slide. And thank you all for your attention. Thank you very much.
Okay, thank you, Fernando, for your wonderful presentation. You are right, very right. If you can't improve if you don't control what you do. So this is my main message from you. So our last speaker is from Romania. She is the Dana Simpoescu. She's an emergency and internal medicine specialist with an extensive professional experience and knowledge in the field of emergency medicine. Her passion is also teaching young medical students at the Faculty of Medicine. In fact, she's the head of emergency department at the Faculty of Medicine in the University of Grigor. I don't know if I say it correctly. And she also is the head of the emergency department at County Hospital St. Spiridon. So Diana, over to you.
Thank you very much for the invitation. I will try to share the screen. Okay. Could you see my screen?
Yes.
Thank you. Thank you very much for the opportunity. And it was very interesting to hear our colleague from different part of the world. And to understand, we have many things in common. So I will speak something about emergency medical system in Romania. This is Romania, 20 million inhabitants, and we are inside European Union. We are on the border of European Union, border with Ukraine and Republic of Moldova. Our system is designed based on emergency medical services coordinated by Department of Emergency Situation, who is the partner of you in this project. We are working in pre-hospital together with firefighter. So emergency medical staff, personnel from emergency department together with firefighter from inspectorate for emergency situations. They are military firefighters. And also we have the ambulance services, the white ambulance. They are also governmental agency under the same coordination, but they are working with only in pre-hospital, having nurses, EMT, and general practitioner with competency in emergency medicine. The system is designed to have together resources from the Ministry of Internal Affairs and Ministry of Health. Ministry of Health, especially for emergency department and ambulance services, and Ministry of Internal Affairs for firefighter and the SAMUR system for ground intervention together with firefighter and helicopters, also together with the Inspectorate for General Aviation. They are military pilots working together with us. Each country, we had 41 countries in Romania, and each country is coordinated by dispatch, integrated dispatch together, ambulance, emergency department, firefighter, and in some country together with police and gendarmerie. And the intervention could be done by type B ambulance with firefighter that we call with medical training that we call paramedics. They are a little different compared with Ireland or UK. The training period it's only 3 months, but we try to increase the training now in the future, in a future year. And we have also the ambulance type B with nurse and EMT from ambulance service. We have intensive mobile unit called SAMUR, emergency physician and nurse from emergency department, and paramedics from firefighter unit. And ambulance service could have a C2 ambulance with GP with competency in emergency medicine. So this is a system, and we have also the possibility to transfer real-time data by telemedicine system. So if a paramedic team will arrive in front of a patient with some disabilities, they can transfer the video and the monitoring information to the physician who is in the dispatch center. And because not all the paramedics, they have enough training for stroke recognizing, they can transfer the information to the physician in dispatch center, and this physician will take the decision for the diagnosis and for what will be the destination, what will be the hospital or the medical center for this patient. And if it's a stroke patient, the decision will be to transfer to a stroke center that we have in each country. Also, we have the possibility to transfer the patient from small hospital, even from the field. If we have the information by helicopter, we run two types of helicopter, Eurocopter 135 and Black Hawk. But Black Hawk is designed more for transfer, not for primary intervention. But for stroke patient, if it's a difficult area, if it's a remote area, we can send the helicopter with a physician and nurse on board. And this is the area that our helicopter could cover all over the country. And we are flying also for Republic of Moldavia. They are our brother and neighbor. So we have different type of hospital in the main university center. The hospital could be general or could be a special design hospital for neurology and neurosurgery. It's of course something crazy, but it's history, and we keep this type of hospital because they have high level of competencies. In the same university center, you can have a general emergency hospital as a trauma center and a special separate hospital for neurology and neurosurgery. And for this reason, it's very important to have the information from the hospital, not to lose time to transfer the patient to the general one, and the stroke program is acting in the other hospital. So we have national protocol and local protocol in favor of our patient, and it's important to have a dispatch coordination 24 hours 24. So these are the numbers about our ambulance intervention in the last year. So 3,200,000 intervention in the last year for ambulance, and another 500,000 for smooth ambulance. And we have the emergency department also in general hospital, also in neurosurgery, neurology hospitals. They are the university center, so capital and some other university center. Emergency physicians, they are located in emergency department, and they receive the patient with stroke. And usually pre-notification exists, but it's possible also that the patient arrive with his family, with his or her car, and the triage will decide, the triage nurse, the triage physician will decide about this patient. Will be, even if it's stable, we will decide to do fast track because it's important to keep the time for the stroke patient. The majority of the emergency department, they we have in the majority of the emergency department, we have a CT scan, and it's possible after fast track to have the CT scan in less than 10 minutes. This is the standard, but the reality is a little different. So in our AD, we had last year more than 5 million patients. That means 25 of the population. So it's important to define what patient has coronary acute syndrome, what patient has stroke, in order to have this fast track to cut the time. Romania in Europe, it's still a red country. It's with a high incidence, high prevalence, high mortality, and with 55 acute ischemic stroke in a year in our country, according to one report. We have an order of the Ministry of Health telling us what are the protocol for this priority, that is stroke. And this is the algorithm, it's in Romanian. So of course, the patient will start the intervention in pre-hospital, continue in emergency department. The emergency department and emergency physician have a high responsibility, so to do the CT very fast, and after the neurologist will decide about the thrombolysis or thrombectomy. Thrombectomy is available only in few centers, so now we decide to increase the number of the patient transfer from a normal stroke center to a specialized center where we could provide thrombectomy as well. The role of dispatcher is important. We have a protocol with target question in order to identify the stroke. Of course, the pre-hospital team has fast or be fast protocol. They try to identify, and also in the last 3 years we introduced also the manned scale coming from Miami University. All of these scale could be used in pre-hospital, but the new protocols that will be published this month will introduce the race score in order to be easier and to provide a better performance of our pre-hospital team. We continue with the physical examination, starting from pre-hospital, continue in hospital, and it's very important, as you already said, to do the differential between stroke and some mimics as hyperglycemia. And pre-notification, it's also important. We have radio and also phone pre-notification. We use radio in the area where the signal is not okay. Of course, treatment for high blood pressure or very low blood pressure, and the information about the family. It's very important to have this phone number, because sometimes the patient is not able to sign the informed consent, and we need some family member to come at the hospital in the same time to sign the informed consent. It's according to our legislation. So we have ground transfer, white ambulance, red ambulance, and we have also HEMS mission who can bring the patient into acute stroke center or comprehensive stroke center when we could provide the thrombectomy. With a red triangle, we have the country with the possibility to treat with thrombolysis, and the blue one are the center who can provide thrombectomy. And the new protocol will increase the number of the center, put one here, some more center for thrombectomy, and the possibility to transfer from the normal center, stroke center, usually by helicopter, but also by grand ambulance to the more comprehensive center. Emergency department has a lot of responsibility, and we try to be in this interval. Now it's 4 to 0.5 hours, but will be increased to 6 hours. Niche, it's the scale for emergency department. And now in this moment, the interval is 4.5 hours for thrombolysis and 6 hours for thrombectomy, but we plan to extend it to 24 hours, as our colleague already mentioned, according to European protocol. So neurologist will come when he will be asked by the emergency department to come, and we try to fix in this 60 minutes door to needle time. The decision about eligibility are according to European protocol, and these are the numbers. For example, if we are looking to this interval 2017-2022, we have 10,000 patients with stroke, the majority with acute ischemic stroke, and the data about thrombolysis, the graphic present us how many of these patients benefit from intravenous thrombolysis. It's not a lot. It's because of the longer patient time. It's the problem, not intervention, pre-hospital and emergency department time, because we need more education for population and more mass media information about stroke recognizing.
1 minute,
different...
Diana, sorry, 1 minute, please.
Yes, these are the graphic about the distribution. So it's unequal. This is a capital, and these are the remote area. So different thrombectomy and different thrombolysis in different part of the country. Uniformity, it's one of our goal. And as I told you, we try to have a new protocol, will be published this month, and to try to increase the time for thrombolysis and the time for thrombectomy, and to increase also the patient transfer to thrombectomy center. So I would like to thank you, and I am open to any question. Thank you.
Thank you very much, Dana, for your extraordinary presentation. So we have some more minutes to answer questions. If you have, please, any question to any of the speakers, please go ahead.
Not a question, but to give a compliment to our colleague from Romania about the last picture of 4 female staff members on the helicopter team.
Yes, I didn't speak before with our colleagues about the holiday on 8th of March, but it's dedicated to the female working in emergency medical service and on helicopter. It's something that I like very much to do, special Sunday, because Sunday is dedicated to helicopter.
Okay. So I have a question for you, Dana. I didn't understand well if the mobile stroke unit is already in use in Romania.
Now it's mobile intensive unit dedicated to all critical patients. It's not only for stroke.
Okay.
So we can, because we have physician on this mobile intensive unit, so could not have a physician dedicated for stroke, and it's not efficient.
Okay.
Nurses and paramedic could deal, except if it's a coma patient, he need to be intubated or resuscitate in the field.
And also you said that you can transfer data from EMS, from the ambulance or helicopter, to the physician at the dispatch center, right?
Yes,
So
from ambulance, from helicopter, we don't
no,
need because we have
the
emergency
doc
physician with
on board.
high
Yeah.
competencies on helicopter everywhere. But from paramedics and nurses, they have everywhere the possibility to transfer the data, video and monitoring data.
Yeah, data and voice, I suppose. But you can share also information with the destination hospital or only with the dispatch center?
We had also the system of telemedicine, but not from ambulance, from small hospital to the trauma center or university centers. So if a patient arrives in a small hospital, the physician in emergency department from the university center, that is also the stroke center, could see the patient and decide we need a helicopter or to transfer this patient very fast because it's a stroke. Maybe we have on duty in that hospital a pediatrician or a dermatologist or
whatever. Yeah, thank you. So Dario, you have a question?
No question, like so far, but I really want to thank everybody. This very interesting presentation, similar to what we did with COVID. It's interesting to see that everywhere really is progressing in very similar manner. That we're getting much more aggressive with the stroke management and the LVOs, and it's very encouraging to see that. And for Romania, I want to thank you. You're amazing. I was in Romania just after the revolution and had
Yes.
worked with Arafat. So, but to see what you've done is so impressive, and everybody's so impressive. But I think that it's interesting how we're all going in the same direction, and information sharing can be very productive. And if there's anything I can offer, please feel free to contact me. But I think you guys are doing great and terrific. I just wanted to comment on that.
Yeah, it's really a global problem, so we need global solutions, right? So sharing information and knowledge is the key, I think. Anyone else?
I'm sure that everybody could invite all the participants to visit the country and to ask many questions, to see many questions, not only Romania, but also Spain and Israel and Ireland.
Yeah. Okay, if you have any question that might arise after the webinar, you can send an email. Michelle, do we have any place to post
I will
a
post the email in
question?
the chat. Yeah.
Yeah.
We do.
Okay. Okay. So the webinar is, if you don't have any more questions, the webinar is finished now at 6:15. So thank you again, everybody, to attend, and I hope to see you in next webinars soon. Thank you.
And I will say thank you as well, especially all the presenters. And for all those of you who want to receive a certificate of attendance, I posted it in the chat. Just fill in the survey and you will be getting one. And as Paloma said, see you in the next webinar. The next webinar will be about sepsis, and it will happen on the 3rd of April. And maybe put it already in your calendar and maybe see you there again. Thank you.